All right, hi everyone. Please welcome Dr. Bill Gallentine, clinical professor of neurology at Stanford University. Dr. Gallentine earned his DO from the Philadelphia College of Osteopathic Medicine and completed his training in pediatrics and neurology at Geisinger and Duke. He specializes in complex pediatric epilepsy, including autoimmune and genetic forms, and brings expertise across a broad range of therapies. As a dedicated educator and active member of leading neurology societies, Dr. Gallentine's research focuses on the role of inflammation and genetics in epilepsy, with the goal of identifying new biomarkers and therapeutic approaches. Let's give a warm welcome to Dr. Gallentine.
Thank you. All right. Everybody hear me? Are we on? Okay, good. Well, thanks so much for coming out this afternoon. Hope everybody's having a great time today and everybody's going to get out and take a chance to enjoy the park some. And so it's really my pleasure to come and talk to you all today. This is one of my favorite events throughout the year. Someone was asking me, why I like this event so much, and it does give me an opportunity to kind of just get out and talk to people a little bit outside of clinic, provide just some insights in terms of how we potentially approach epilepsy, but also to hear your stories. And so I really just enjoy and appreciate the opportunity for this afternoon. One of the things that Brad asked me to talk about today is a topic that I just pretty much do every day of my life, and that's selecting a seizure medication that ultimately might be right for you. So we'll kind of walk you through. You kind of get a look behind the scenes of what's going on in your neurologist's brain whenever we're actually trying to choose a medication, and hopefully provide some insights there. So the first part of this is who do we treat? And so, and really it comes down to ultimately you having a diagnosis of epilepsy. And so as you know, the definition for epilepsy is having at least 2 unprovoked seizures that are greater than 24 hours apart, or 1 unprovoked seizure, and then having some chronic predisposition for that actually has a risk of more than 60% of a seizure recurring that ultimately then leads to your diagnosis of epilepsy. Okay. The other scenario within that as well, or part of that, is also if you're diagnosed with an epilepsy syndrome, you also would then be treated, and that epilepsy syndrome is going to fall underneath those 2 diagnostic categories that we just mentioned. So let's get a little bit into this who do we treat type of thing. And a lot of it comes down to whenever we're doing our initial evaluation of someone who's had their first time seizure, we're looking for that second box to check. Who's at risk for having that second seizure that crosses this threshold of more than 60%? And by far the test that we do that actually gives us the most information on who's at risk is going to be an EEG. Okay, and so everybody who has their first seizure gets an EEG, and with that we're looking for sparks or looking for little spikes on the EEG that would show that you're at risk for having seizures return in the future. And you can see what's kind of laid out here, that if you're someone who has had their first seizure and their EEG is normal, the likelihood of you having a seizure recurrence is somewhere between 20 to 40%. So you're not going to cross that 60% threshold that we kind of talked about. If your EEG is abnormal, it's going to fall someplace in between 55 to 65%. And I'll talk here in a moment about the specificities of kind of what some of those EEG abnormalities are and what they do to the statistics in a moment. If you're someone who actually have had a remote symptomatic etiology, meaning that you've actually had some type of injury to the brain, that increases your risk of recurrence relatively high, up over that 60% threshold, which is why if you have an underlying neurologic deficit or an abnormality on your neuroimaging per se, then that would be high enough that we would think about going ahead and starting you on a medication. When we think about recurrences, this is a question that I frequently kind of get from families, is, well, how long do I have to wait before I know whether the seizures are going to return or not? And the majority of folks are going to recur within the first 2 years. You can see that 50% recur after 6 months, and then 1 year, 70%, and another, by 2 years, 90% recur. If we're looking at those EEG findings, sometimes we'll have focal findings or little spikes that are occurring in one particular spot, which would imply the seizures are potentially starting from one particular spot. That too bumps your risk up over 60%. Other times you may find what's a generalized spike wave, so the entire brain kind of fires electrically all at one time, and again, that bumps you up over that 60% threshold. So if we're seeing those types of abnormalities, those are the ones that actually pick our, kind of pick us up and say, that's one that we need to potentially try to treat. Slowing is something that you may see on an EEG that actually refers to the brainwaves moving slower in one particular area quite often, or generalized, meaning in the entire brain moving slower. That is not what we would consider an epileptic abnormality, so that's not something that puts you at risk for seizures per se, and you can see that it doesn't really put you up over that threshold for which we would eventually decide to treat you based upon that and just having one seizure. And so if after you've had your first seizure, again, about 30% of people are going to have that second seizure within 5 years. And then after that second seizure, about 65% are going to have that third seizure within 5 years. So this is why that second part of that diagnostic, or that first part of that diagnostic criteria, where you've had 2 or more seizures, gives you the diagnosis of epilepsy. It's based upon that data right there. And again, about 2/3 of the recurrences occur within 1 year of the preceding seizure. Okay. So now we're going to set the stage. So now that we kind of know who we treat, we're going to kind of set the stage a bit here in terms of anti-seizure medication. And these are just kind of general rules of thumb. So about 50%, 60% of the patients that we start on a seizure medication are going to respond to their first medication. It may take some tweaking of the doses, and so it doesn't necessarily mean the first dose we put you on, but at least that first medication, we're going to kind of work through that. And then another 10 to 15% are going to respond to their second. After you reach that second medication, if you failed that one, then both your medicines have been chosen appropriately, there's less than a 10% chance that we're going to get seizure freezing with a third medication. So odds really start to drop off, and that's how we end up getting this group of about 20 to 30% of patients that are drug resistant. And so now, within that patient population, though, adding in an additional seizure medication, again, in general, about 50% are likely to have a greater than 50% reduction. So this is why we often are trying different medications. Every once in a while, you're going to find that magic one that may actually put you into that less than that 10%. But in general, it's about a 50% chance that we're going to actually get a 50% reduction, which is why once we get to that point, we start looking about other options in terms of treatments. Okay, so this is a list of all of the different seizure medications that are currently available on the market. So that is a long list. So there's about over 30 medications listed there of medicines that we actually have available in our toolbox. If we looked at that back when I started my training, there was probably about half the medications that are on this list. So this really has been an explosion of medicines that's become available over the past 10 to 15 years, and there's more and more medications that are currently in the pipeline. Many of these have multiple different approaches. This is a slide just of mechanism of action. Not that this is going to be necessarily all that meaningful to you in particular in terms of knowing the specific mechanisms, but to show that there is multiple different ways in which these medications work. And the name of the game with epilepsy, at least at this point, has predominantly been the balance between excitation, so having too much excitation, which ultimately then leads to a seizure, versus lack of inhibition, having the ability to kind of dampen down that abnormal electrical activity. And the majority of the seizure medications that are on here work through those types of mechanisms. They either try to dampen down that excitation, or they rev up our ability to inhibit it. And a lot of these medicines not only work through just one potential mechanism, but they may have multiple different mechanisms by which they work. Now, mechanisms are also important not only because they actually can impact and can reduce seizures, but it's also the same reason why we get side effects. Okay, so these medications not only sometimes they're focused on specific types of cells, specifically the ones that are causing seizures. But as we increase doses, they do start to affect other types of nerve cells as well, and that's why you can have some of the very common side effects that we run into with seizure medications involving cognition, sleepiness, drowsiness. Those are all common side effects that if I give you enough of a medication, they can do that. And so that's just these mechanisms starting to work on other types of cells that can cause those types of symptoms. So now we're going to kind of get into some of the special considerations that we think about whenever we're selecting these anti-seizure medications. And so we oftentimes will start with seizure type. We'll take in consideration an age, an epilepsy syndrome, or a genetic underlying diagnosis. We think about the side effect profile, the drug formulation, drug-drug interactions that they may have, any other conditions that you may also have, we may take into consideration, and then parental preference, and specifically kind of making some joint decision-making with you as we kind of talk about each of these. So we're going to go through each of these little sections here in a little more detail. So one of the first things that we oftentimes try to distinguish then is what seizure type you have. And so, and in breaking it into the two broad categories of generalized and focal, we have different meds that are approved for different types of seizures and have been proven efficacious for different types of seizures. So on the generalized side, there are a number of other sub-generalized type seizures, many of which you guys are very familiar with. So things like tonic seizures, where the entire body kind of stiffens, tonic-clonic, where the body may stiffen and then have a rhythmic jerk, absences, where they may have staring with behavioral pauses and arrest, and that may occur in two different flavors, typical and atypical, with the differences there actually being what we see on EEG, not so much what we're seeing on the outside, although atypical absences have a tendency to be a bit longer than what we see with typical absence. Myoclonic seizures being little rapid twitches or jerks, atonic seizures where you lose muscle tone and drop to the ground, and then infantile spasms where you actually will have a little posture that could be either flexor or extensor, where your arms go out or in just for 1 to 2 seconds and then relax. So those are all various different forms of generalized seizures. So whenever you're talking to your doctors, you'll find that they'll spend a fair amount of time trying to get a description of what the seizure is. And the reason is we're trying to identify which of these types that they may be, because it's going to help us select our seizure medications and also potentially sway us towards what therapies might be the best option for you. The same thing kind of goes for focal seizures, which actually start in one particular spot. The behavior that accompanies a focal seizure, so remember these seizures are going to be abnormal nerve cells firing in one particular location on a focal seizure, and depending upon what the function of the brain is in that particular area, your seizure may have a behavior that accompanies that. So if it's starting in just an area of a hand, in the motor area of the hand, you might get jerking of the right hand. If it spreads up to the face, you might get the face jerking as well. If it spreads to the leg, you can get right arm, leg, and face all jerking. If it spreads to the other side, you can actually get entire body shaking. And then if it doesn't involve a motor area at all and involves more of the temporal lobe, you may get just more staring and confusion or speech arrest. So it just depends on where that seizure starts, where you can get various different types of seizures. And so, and again, your neurologist oftentimes will ask you specifically to try to get very pointed description of your seizures, because they're trying to localize where those seizures are coming from and ultimately determine what the best options for you may be in terms of treatment. So whenever we talk about generalized epilepsy, and these are just broad rules of thumb, so on the left, whenever there's the starred are the ones that are classically shown to be helpful for generalized seizures. So things like valproic acid and levetiracetam and lamotrigine, topiramate, clobazam, and lacosamide. Those are ones that are classically used for generalized convulsive seizures. And then you can add ethosuximide to that list there of medicines that are particularly helpful for absence seizures. Then there's a whole other list of medications that we then kind of just try to add on when things aren't going as well as we would like, that also have been shown to kind of have some efficacy. So you can see there's a long list of meds there with that. The focal seizures, again, you're going to see a lot of crossover. So a lot of meds that was on the list that I just showed you for generalized is also on the list for focal. And that's because these medicines are somewhat broad spectrum in some cases and cover lots of different types of seizures. So medicines that we commonly will use first line for focal seizure would be levetiracetam, oxcarbazepam, lamotrigine, lacosamide, and so oftentimes based upon side effect profile. But there are a number of other meds, and there are no right or wrong answers with any of these medications. A lot of them is kind of discussions about some of the other points that we're going to make in terms of why you picked one over the other. But you can see big lists for both of those. So whenever we then break it down a little bit further and we look at, okay, now we've got generalized, but then we start looking at generalized plus the seizure type that you have, then you can start pocketing a little bit more in terms of which medicines potentially are more helpful. So if you take something like infantile spasms, which we talked about, here we typically would use steroids, either oral or injectable or vigabatrin. If you're looking at like atonic seizures, medicines like valproic acid, clobazam, lamotrigine or phenamide, felbamate, paramate are oftentimes kind of more classically used and have the best amount of information that we have of efficacy within that group. And then there are, again, when we look at the bigger group of generalized tonic-clonic seizures or myoclonic seizures and associated with those, you have that whole other subset. Absence, you have ethosuximide as a primary treatment, but valproic acid and lamotrigine are also very good as second-line therapies. And then the same thing kind of goes for the focal. All those ones that I listed on the previous slide, you can see are kind of listed here. I do want to pause here for just a moment and go back to the point that I had made previously about the percent of people that respond to their third medication once they've failed two. If you remember, that number was less than 10%. It's important to not necessarily get hung up on medication after medication after medication without actually taking a big step back and making sure that you've had an epilepsy surgery evaluation. Because the numbers of adding an additional medication is so low, you always want to make sure that you're not someone who has a surgically treated epilepsy, because that could be the one opportunity for cure, whereas the others are going to just be symptomatic management with the seizure medications. And so not everybody is a candidate for epilepsy surgery, but it is very important to take that step back, see an epileptologist with experience with epilepsy surgery, and make sure that you're not a candidate for that, because it could very drastically alter your course for where you need to kind of go. That being said, if you're someone who doesn't respond or are not a great candidate for epilepsy surgery, or at least, my job, I kind of look at it as I have to spell out options for you guys in terms of, what are the next of options that we have to think about. And usually when we're talking about refractory epilepsy, there's four options that we're thinking about. We're thinking about medications, which we already talked about. There's surgery. And then there's also ketogenic diet, and then some form of neuromodulation, which is a neurostimulator device. So vagal nerve stimulators, implanted intracranial stimulators that also can be options. So we kind of keep all of that in the back of our mind as we're kind of approaching these, and it's important to kind of recognize that as we're kind of going through this. So we also have seizure medications that are geared specifically for age, so specifically for neonates. So neonates, unfortunately, we have the least amount of great scientific data showing efficacy for certain medications. So I showed you that list of 31 seizure medications I have there. You can see how many of them have actually been very well studied here in the neonatal population. So there's a huge lack of data when it comes to neonates and their seizures. And we have things like phenobarbital and fosphenytoin, levetiracetam, lacosamide, midazolam, lidocaine, and then vitamin B6. That's really it. That's all. Now, we certainly use other medications in those babies that have very difficult to control seizures, but the data to support that is actually quite low. So definitely a lot more information is needed in terms of where we kind of go in terms of the neonates. So I had mentioned epilepsy syndrome as another way we select your seizure medication. So what exactly is an epilepsy syndrome? Okay, so this is a group of signs or symptoms to really help define a unique epilepsy condition. It may actually have multiple different causes. Okay, typically this is going to take into consideration your seizure type or multiple types of seizures that you may have, but it also includes your EEG features, the effects that they may have on development, physical exam findings, neuroimaging findings, genetic testing. All of these things kind of come together and help us define a specific epilepsy syndrome. And if we have that, then we can really say, okay, in that more clear clinical picture, is there more evidence to suggest that one particular medicine might be more helpful or one particular treatment might be more helpful? So really defining that epilepsy syndrome, and again, that comes back to the history, but kind of delineating what's kind of going on and then using the EEG features to try to piece that all together. It is important to recognize, though, that not everybody fits into an epilepsy syndrome. Sometimes the epilepsy syndromes actually cross over each other, and so sometimes this is not as clean as what you would like. But there are over 40, nearly almost 50 epilepsy syndromes that have been defined that is out there. So we just look at some of the more common epilepsy syndromes and some of the choices just to kind of illustrate what I'm talking about here. So the childhood absence is by far one of the most common childhood epilepsies that we have. You can see there's a long list of medications that are there, but ethosuximide, valproic acid, and lamotrigine are going to be your hallmarks within those. It's also important to recognize that some epilepsy syndromes may be made worse by certain medications. So things like carbamazepine and oxcarbazepine may worsen childhood absence. So we would want to avoid those. Or if I'm seeing a patient who's having very, very frequent absences and they're on one of these medications, it's important for me to recognize to get them off of that. So things like juvenile myoclonic epilepsy and juvenile absence epilepsy, valproic acid, levetiracetam, lamotrigine, in particular, again, are medicines that are there. But you see, it's a long list of other things that you can consider. But also important to recognize that things like lacosamide and lamotrigine may worsen myoclonus. So if I have someone who's on one of these medications and they're worsening, then keeping in mind that that's something that with this particular epilepsy syndromes that you can potentially see. So then we have meds for like Lennox-Gastaut and infantile spasms. Dravet syndrome in particular is one to think about. So this is, for those who aren't familiar with Dravet syndrome, this is a genetic epilepsy that has a defect in a sodium channel. So sodium channels are very important in terms of conduction of electricity within the brain. And folks who have this particular genetic disorder have problems with the amount of sodium that comes in and out of the cell. And it creates electrical instability and very difficult to control seizures. And so classically, there have been some medicines that have been particularly helpful for this. So valproic acid, clobazam, levetiracetam. And then more recently, there's been specific drugs that have been tested just for this specific syndrome. So things like Epidiolex, fenfluramine, stiripentol have been specifically targeted to look at the specific genetic syndrome and show efficacy within that specific epilepsy syndrome. Again, also important to recognize the syndrome because there are some medications that will make it worse. And so particularly medicines that actually impact how the sodium channel functions oftentimes may lead to worsening seizures. So as an epileptologist, it's important for me to recognize this syndrome, diagnose it, and not start you on one of these medications. And so there are other things like autosomal dominant nocturnal frontal lobe epilepsy, which has a treatment that we would not necessarily traditionally think of, a nicotine patch. And so this would not be something that I would just go and give any patient with epilepsy. So this is very targeted, specific toward this specific genetic defects because it actually affects acetylcholine receptors, which actually are actually impacted by nicotine. And then there's other things like electrical status epilepticus of sleep, so ESES, which is basically an epilepsy syndrome that has continuous electrical status epilepticus while your child is sleeping at night, and it can have a substantial impact on development. So that actually has different treatment than we would typically use, where we would actually consider more steroids or really high-dose diazepam, much more than what we traditionally would use for just regular epilepsy. And in fact, diazepam is not something we routinely use for regular epilepsies, but does have an indication in this specific epilepsy syndrome. So this is where the epilepsy syndromes really, hopefully you're getting a sense for this, really kind of helps us sort that out. This is becoming even more complicated as we're doing more and more genetic testing. So a couple years ago, the American College of Geneticists had come out with a blanket statement saying that all patients with epilepsy should have a have a discussion with a neurologist about the possibility of genetic testing, with a strong recommendation for having genetic testing done with all patients with epilepsy. And this is the reason why, because we are finding more and more genes that have specific indication or specific treatments that are indicated for those disorders. And in some cases, it may not necessarily be a medication that is clearly aimed at treating that disorder, but it may also be avoiding certain medications that may make things worse. And this is only going to get better. So I've been very fortunate over the course of my nearly 20 years now of doing this, that the landscape has changed so much within neurology in terms of the types of care that we are given. And many of the disorders that we've seen, particularly my colleagues who are in the neuromuscular world, where there are actually some genetic cures for some of their neurologic conditions. And so these types of therapies are coming down the pipe for epilepsy, and they're going to be here soon. And so they're going to be very targeted, and so they're going to fit certain subsets, and it's going to look something like this, where you have a gene, and then you have a target at that gene. But more and more of these types of therapies eventually are going to become available. So if you don't know what your genetic diagnosis is, it's very difficult for you to actually then qualify for one of these treatments. So that's why it is very important to at least have the discussion. Now, does that mean that every patient who has one of these really common childhood epilepsy syndromes that have normal development and their seizures are well controlled and they're doing great and we expect them to outgrow it, that all those patients need to have genetic testing? Probably not. But certainly in those folks, at a minimum, those folks who are actually having refractory epilepsy, or their course is not taking the typical course for which we would expect, definitely should take the step back and take a look at the genes, because it may ultimately, even if it doesn't give you an option right now, in the future it potentially will. All right, so it's also important to kind of make a comment that, what is the ideal anti-seizure medication or anti-epileptic medication? And so the ideal anti-seizure medication really would prevent or inhibit excessive pathologic nerve cell firing, so the abnormal electrical discharges, without really having any side effects. So that sounds great. So we're going to prevent all the seizures, and we're not going to have any side effects. Unfortunately, we're not there yet. That medication doesn't exist. So if you actually go and look at your package inserts, you're going to find a list of 1,000 things that potentially could happen whenever you take a seizure medication. Now, fortunately, the majority of folks, we can work around those side effects, and we can get you on a seizure medication and try to minimize those side effects as much as possible. But we certainly have not gotten there yet. And certainly any of them, because we talked about previously, other nerve cells starting to get involved whenever we start getting, particularly once we start moving up on higher dose, almost all of them have the potential to cause some form of cognitive side effect, dizziness, fatigue, mood or behavioral side effects, headaches, balance issues, any of those types of things. Now, whenever I'm about to show you a slide of the most common, let's pull it up now. So this is the list of the most common side effects that I will typically talk about whenever I am discussing certain medications. Now, I just mentioned to you that you're going to pull up that package insert and you're going to see there's 200 or 300 or side effects that are potentially listed there. And so as a physician, I don't typically go through every one of those potential side effects. What we say is that we're going to give you the most common ones, the things that we really have to kind of focus on. But then anything else that you kind of experience, you reach out to us, and then we have a conversation about whether we feel like this is impacting as related to the medication or not. But you can see, and I'll kind of spend a moment going through some of these, because some of you guys may be on some of these medications or at least have heard about these medications before. So valproic acid, by far the most, again, we use this for generalized epilepsy. By far, weight gain is probably the biggest side effect that we see. We also worry about effects on blood counts, specifically platelets, and we also worry about liver dysfunction. And so there are a number of other things that we potentially worry about as well, but these are going to be some of the common things. Levetiracetam and breviracetam, we're going to think about behavior disorders and depression. And so by far going to be the most common side effects that we potentially see. Lamotrigine, we're going to focus in on rash. So it can have a very severe rash that oftentimes will have blistering of skin, looks like burns. Fortunately, we're able to minimize that as much as possible by just going very slow on the dosing and then stopping it as soon as any rash develops. But you can see the incidence there is about 8 in 1,000 kids, and 4 in 10,000 adults. Insomnia is also a very common side effect, as well as dizziness. Topiramate, very low risk of kidney stones, but I always talk about it because if it happens, you want to know why I'm all of a sudden having this severe flank pain. Or if your child who may have autism and has problems communicating, if they're acting not right and they seem to be in pain, you need to know that there's a risk for a kidney stone there so that we can look for that. But by far, more commonly is decreased appetite. Cognitive side effects potentially is a little bit higher with topiramate. They also can have decreased sweating and paresthesias. Similarly, zonisamide also can have decreased appetite, kidney stones. They also can have decreased sweating, and then because it's a sulfa drug, they can have rash. Ethosuximide has stomach ache. So I won't go through each of these, but this is the type of conversation that we would typically have if we're going to say, okay, we have 3 or 4 medicines that I'm thinking of using. Here's the things that I worry about and I think you need to know about, and we're going to be looking for. And with that, then you kind of make a joint decision. And again, this is probably one of the most important ones whenever I'm trying to think which one's right for you in terms of trying to make a selection. Another thing that we want to think about is drug formulation. So, can you swallow a pill? I got many children who just aren't able to swallow a pill. So what are my options? Some will have syrup. Others will have dissolving or chewable tablets or a dissolving film that you could potentially use. Others may have sprinkles, and so that you can sprinkle and mix into food. We also have to take into consideration, for patients that are hospitalized, does it come in an IV, or do I have to put it down a G tube if people, or an NG tube if people are not able to swallow? How big is the pill? Is it a big pill, a small pill? Can we get over that if it is a larger pill? And then extended release, and so which is another thing to kind of consider whenever you think about trying to stabilize seizures. Sometimes being on medications that actually are released over 24 hours, and actually even using them twice a day, sometimes can result in higher, smoother levels that may allow you to kind of stabilize your seizure some, in terms of particularly if you're able to keep that level in a more stable range. So all these things we kind of take into consideration then in terms of what the formulation is and what we feel like is best for the patient and the family. We also take into consideration drug-drug interactions. So what meds are you on? Very frequently we'll have kids who are on more than one medication. And these medications may interact with each other. So some of them may slow down the liver, resulting in an increase in some of the medications. So classically, valproic acid does that. It can cause some of your other medications to go really high if you don't make an adjustment. This can result in more drowsiness, more sleepiness, and this greater toxicity. Others may speed up the liver and make it go more quickly and break down other medicines. So I may actually be therapeutic and having minimal seizures, but still having some seizures, but add another medication in, and all of a sudden seizures get worse. Well, why'd that happen? Well, my new medication isn't high enough to control seizures yet, but it is enough to speed up the liver, and I just dropped the level of my other medication. So you have to take that into consideration and make those necessary adjustments as you're adding medications in. And there are some classic drugs that are oftentimes very frequently impacted by other drugs, specifically lamotrigine, valproic acid, clobazam, and more recently Epidiolex. Medicines that have minimal drug-drug interactions are ones that really aren't cleared by the liver. So levetiracetam, brivaracetam, lacosamide, and topiramate. And then other things that are important is other comorbid conditions. So if you're an oncology patient and you are getting chemotherapy, I got to be really careful with what I'm going to be doing with my other meds if they're going to potentially impact your other therapeutic drugs. So we have to be very cautious in terms of that. Same thing goes with behavioral medications. So I may make you toxic on those depending on what I add in, or vice versa. Their medications may actually impact the levels of my medications. So working in close tandem with other practitioners so that way we know what other meds are going on is important. Birth control pills. We may actually impact the efficacy of birth control pills in terms of how they work. And then I just put this as a kind of in a way of a public service announcement, is that remember vitamin D supplementation. So particularly for enzyme-inducing meds and meds that rev up the liver, those will make you break down your vitamin D quickly and put you at risk for fractures. Same thing goes for valproic acid, which is, although it doesn't actually rev things up, it does have a negative impact on bone health and soften bones. So those meds should be on vitamin D and should remember that point. So then the next thing we want to think about is, well, what are the other conditions then that we often need to be thinking about? Because sometimes some of the treatments that we're going to use may have either side effects that can worsen another condition, or they may actually be beneficial, and so they actually can treat another condition. So, for instance, autism. So I probably want to avoid meds that worsen behavior, so things like levetiracetam, parapamil. Doesn't mean that you can't use these medications, but if there are other options that I can try first, that's the route we want to go. If there's underlying depression, we want to make sure we potentially consider using meds that may actually treat depression, so lamotrigine, pregabalin, whereas I might want to avoid medications that may exacerbate depression, so levetiracetam, brivaracetam. If they have bipolar disorder, we want to try mood-stabilizing seizure medications. If they already have an underlying diagnosis of ADHD, things that notoriously potentially may impact your cognition, like topiramate, you might want to avoid, or things that actually may worsen behavior, like levetiracetam, you might want to consider avoiding. Migraines, and so is another one. So migraines is one that oftentimes we can treat with topiramate or valproic acid, but also treat your seizures at the same time. If there's already underlying cognitive impairment, we already talked about that as a potential side effect of topiramate, so we really want to kind of take that into consideration when we're adding it in and truly try to avoid higher levels if possible. If obesity is already present, then we really want to be careful about using valproic acid because that actually can cause weight gain. So we want to avoid that in that circumstance. The same thing goes for pregabalin. I've had patients gain 10, 15 pounds on those medications, so you've got to be really careful with that. Whereas topiramate and zonisamide, because of their decreased appetite side effect that you have, may actually help in that scenario because we may actually lose some weight. So something to kind of take into consideration there. If you have failure to thrive or an inborn error of metabolism or an eating disorder, you might want to avoid medications that actually decrease your appetite. So, and specifically for the inborn errors of metabolism, some of those actually are made worse whenever you don't have the fuel to actually, if you can't process fuel appropriately, and so they can get really sick. So, avoiding meds that can decrease appetite would be something to consider there. If you had a history of kidney stones, or if you're on the ketogenic diet, which increases your risk for kidney stones, avoiding meds that also can then cause kidney stones, like topiramate, zonisamide, acetazolamide, would be something to consider. Mitochondrial diseases, those specifically POLG and Alpers, those actually can be put in a metabolic crisis by valproic acid. And then for children that are of women or women of childbearing age, we then also want to think about birth defects that can occur whenever you're on these medications should you get pregnant. And so things like valproic acid and phosphatidone and carbamazepine traditionally have been associated with those and are important to recognize in that particular group. And then lastly, if you have swallowing problems or on a G-tube, it's important to recognize that some of the sprinkle medications sometimes can clog the G-tube, so that might not be a great option within that group. So you can see a lot of these things now. So we've kind of worked through our list of things that we've been thinking of, and now we're also taking into account the patient as a whole, other things that may be going on that allow us to kind of then make this judgment. And then lastly, but not necessarily least of important, actually probably most important, is the parental preference. So it's your kind of final consideration. So, basically how I would do this is we would set the stage. So we would actually just kind of walk through all those different reasons for why this medication, that medication might be good, what are the potential side effects, and then take into your thoughts on which of the medications might be the best option for that. So we really kind of make joint decision making then in terms of how we want to kind of do that. We always discuss the multiple treatment options and their potential side effects. We are going to, again, consider those non-pharmacologic options like the surgery, the ketogenic diet, forms of neurostimulation. One thing I didn't mention, but also one thing to keep in mind is that some of these medications do require blood monitoring. So as you can imagine, in pediatric situations where needle sticks are not always a fun time, that may come to the decision as to whether we want to start something like lamotrigine, which doesn't really require a lot of blood work, versus valproic acid, which requires a lot. Another thing to kind of keep into consideration is non-compliance can be really challenging in kids. So both young kids who just keep spitting out their medicines, or adolescents who just say, I don't want to take this medication, you can't force me to take it. So really working with, particularly for the latter group, working with them on what don't you like about this medication? Is there something that I could do to make this more desirable? We have multiple different preparations. Can we figure out a way to find something that you like? Is it a specific side effect that's bothering you that you don't like? Really trying to get down into the nitty-gritty of that is really important. And then the other thing to kind of think about then is, oftentimes, particularly when you start talking about the side effects, I oftentimes get this look from parents like, why would I put my kid on any of this stuff? It sounds horrible. It really is balancing the risk of side effects versus the risk of seizure injury, right? And what we're trying, and that's really what we're ultimately kind of trying to avoid. And and usually I kind of focus on the risk of potential side effects because we don't want to be paralyzed by the potential of a side effect that may not actually occur, but we just have to recognize that it's a possibility, and if we see something, then we make a change as needed. So, and then I always kind of pass, the last thing is anytime we have a suggested therapy, we want to pass it through the filter. Is what we're recommending really truly going to have an impact on their quality of life? And if so, how? And it's kind of really kind of ask that question, and that way it kind of sums everything up and really why we're doing what we're doing. So those are all the things that, as a neurologist, I kind of think about whenever I'm thinking about prescribing a medication. I think we can stop there, and then I think we have some time for questions. We have 4 minutes. So, yes, start front row and then work our way back. Absolutely. Yeah, things have definitely changed. If it's been that long, absolutely. So the recommendation now is actually for whole exome sequencing. So many people who've had genetic testing in this room probably had panel testing, where they actually probably looked at 300 of the most common epilepsy genes. That has evolved now, and because we have now found more and more genes, and the price has come down so much on whole exome, that the recommendation is now for a whole exome. Regardless, there's also the possibility that if your testing was negative, that the technology just wasn't good enough to detect things that they're detecting now. So, in fact, it's really recommended every 5 years or so that it's revisited because the technology is moving so fast. Folks who have been found that have like a variant, meaning where they found one abnormality, but they're uncertain as whether it may have changed, that too is something that could evolve, and then as with more information has become available, now things that they didn't recognize as being pathological before are now being recognized. It's important to know what you're actually getting back whenever you do a whole exome. So basically, they're testing, all of the exome, which is all of the portion of the DNA that actually is making all the proteins in your body. And so, but they're not reporting that back to you, or me actually. If they were to do that, they may provide me with a list of 2,000 variants that they've found that may not be significant. What they do then is take the clinical information that I provide them and then try and match it up to make sure that it's actually clinically significant. So what that results in is if there's something that's not a lot known about a specific gene or something like that, then later on down the line, more information is found. Now all of a sudden something that wasn't significant 5 years ago is significant now. So important to get that testing redone. Let's get back to the room actually. Yeah. Yeah, I think it kind of speaks to the fact that once you've even failed your first medication, you're already kind of making taking a group that's already going to be very difficult to control. They're in that second group. So there's only a smaller number of folks that are actually ultimately going to be responders. Now, why does that happen? Why do people not respond to medications? Some of it may be their genetics. Some of that may be their ability to actually transport certain medications into the brain. So there's different transporters, and some people have better functioning transporters than other people. Some people clear medications in different ways. So there's multiple different, and then oftentimes it's the underlying pathology. It's just that particular type of pathology is very resistant to the treatment medications. Yes. Yeah, that's a great question. That's one I get asked quite a bit. And so at this time, there hasn't been any great studies to suggest that definitively, yes, a certain cognitive behavioral therapy or exercise, anything like that, actually truly has an impact on seizure frequency or can ward off a seizure. That being said, there's been studies that have kind of looked at yoga and stuff like that may seem to kind of have some potential impact. I think a lot of those things are probably aimed at stress reduction, which likely does have a positive impact on seizures as a whole. And so doing those types of practices, getting good exercise, doing those types of things, getting good sleep, all those types of things seem to have a positive impact. And getting good sleep is probably the biggest thing that you can do to try to help with your seizures, is staying on a good sleep schedule if you can. There was another question over here that I missed. Yeah. That's a great question. It happens very frequently, actually. So let's say you're someone who was having tonic-clonic seizures, and then all of a sudden now you're having absences. We would actually, one, I may try to pick a medicine that treats both types. So there's a lot of overlap. If you remember that slide I showed you with the different types, a lot of the meds are on one box, we're also in another box. So one strategy, because I'm always trying to keep you on the least amount of medicines possible, is to try to pick a med that covers both types. That being said, I might be excluding the most effective medication for that one particular seizure type if I do that. So depending on how difficult the seizures are to control, I may say, that was hard to get that one controlled. I don't want to take this one off. Let me try to add in ethosuximide in that scenario just to address the absence. So it really kind of just depends on kind of where we're at and kind of how easily the other seizure was controlled, and then what my options are. That's a great question. Other question? Yes. I'm sorry, I didn't hear that. Yes. Yep. That's a localizing feature. Yes. So remember, I was talking about focal seizures and how seizures start in one particular spot. Eye movements would be considered a focal finding that kind of helps us decide is it coming from the right side or the left side of the brain, depending on which direction the eyes go. So it's one of those other features. But you can get lots of things like, we mentioned movement of the body, but you also get like flashy lights that may implicate like back of the brain kind of thing. That's another one. So it just depends on kind of where you're at. Congrats. Yeah. Yeah. Yep. 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 Yes. Yep. Yeah. So I'm gonna answer a broader question with that, and then I'll come back to that. So the question that she's asking is can we wean? Is it a good idea to wean? And that's where coming back to that epilepsy syndrome is important, right? So or your underlying cause, because I know that in kids that have juvenile myoclonic epilepsy per se, over 90% of those patients are going to require lifelong treatments. And so in that scenario, if you fail weaning, I would say there's no reason to wean because of your epilepsy syndrome. If you have generic generalized tonic-clonic seizures, you don't fit an epilepsy syndrome, then it may be worth trying to come off because your likelihood of potentially being successful with that is much, much higher. And then we would do testing to kind of try to further assess your risk. So EEG is going to be the gold standard for that. So if you do an EEG and the EEG shows that there's an epileptic abnormality still present, if we take you off the medicines, there's probably about 80 to 90% chance that you're going to have another seizure. So the answer would be no, we would not take you off that medication. If we did an EEG and the EEG was normal and you don't fit one of those epilepsy syndromes that are likely to recur, then the likelihood is about 20 to 30% chance. And even though you failed in the past, it just means that was not the right time for you to come off. It doesn't necessarily mean you have to be on the medicine forever. Now, I don't know your full story or things like that, and whether there's other things or not. So, and your doctor would take that into consideration. But again, if you fit one of these other syndromes, you have to kind of just take that into consideration. And I think like juvenile absence is 60% recurrence rate. So some people may say, oh, that sounds really high, 60%. I'm going to stay on my medicine. Okay, that's perfectly fine. Other people say, well, that's 4 out of 10 people on medicine unnecessarily. We want to try to come off. So those are just the conversations that you kind of have with your neurologist in terms of making these decisions on whether you want to come off the medicine or not. But yeah, exactly. Yeah, you should never just stop your medications abruptly. It should always be a weaning. Yeah, it should always. Yes. Yeah. The other caveat there I did want to mention is if you had a neuroimaging abnormality there in that situation where your MRI actually was abnormal, that in and of itself probably puts your recurrence rate about 50%, even if your EEG is normal. If your MRI is and your EEG are both abnormal, very, very high recurrence rate. So it wouldn't come off in that area. Okay. Sure. Let's see. We got time for another question or two. Well, we would define a failure by actually having an adequately dosed level. So adequately dosed, and usually that means that we're going all the way up on weight-based dosing as high as we can go based upon the weight-based dosing, and then I'm getting a level to see if it's actually as high as I think you would actually push it without getting toxicity. And so that's where we kind of define our upper limits. And then you keep, this is one of the greatest frustrations for both parents and doctors is it is very much a trial and error basis in terms of starting the medication and then ramping it up. Because what we don't want to do is to start you on a medicine and take you all the way to the highest dose. Because one, that increases my risk of side effects whenever I do that, and I may not need that high a dose. There are some patients that will respond at that initial dose. So whereas there are many patients that does require that moderate dose or that even that high dose. And there's no great way of predicting where you're going to fall. So, but oftentimes I get this complaint from parents, or hear this complaint whenever they've seen other doctors and they're coming to see me for the first time. Oh, they just kept turning up the medication. They just kept increasing the medication, and so it's clearly it's not working. Well, what they're attempting to do there is work through that progression and then kind of move through the next dose. Now, the key is that being really aggressive, though. So I do advocate for being aggressive with, as you're having seizures, you should be making changes in the meds, or at least having discussions as to why you're not, and then quickly move to the next one if it's not working, and then move down that progression of looking at what your options are, because it may be that medications aren't the best option. Maybe you need diet, or you need a VNS, or you need a surgery. Yeah. Yeah. Swing by here afterward. I have another comment, but I'll just make it on the side whenever we're done. Molly, you had a question? Why do seizures hurt? So where do they hurt? Yeah, well, sometimes I get seizures hurt because they actually may, either because of the tightness that you get in the muscles whenever they occur. Oftentimes that'll make, it's kind of like getting a big workout and your muscles get really kind of tired and stiff, and sometimes that's what kind of hurts. And so that stiffening of the muscles. Yeah, sure, good question. Say that one more time. Yes, absolutely. And you can, for whatever reason, we do see some set of patients that they are well controlled for years, and all of a sudden they lose their efficacy. And whether that's because their body's way of processing the medicine has changed, it doesn't happen frequently, but it can happen. Yep. Probably the biggest thing that, and this gets the point that I was going to kind of make with you actually, is that so the medicines that fall into the benzodiazepine family, so clonazepam, clobazam are ones that are classically used to kind of treat with. They do have what's called tolerance that develops that usually it works for a few months and then it stops working, then you have to increase the dose, and then after a few months you have to keep increasing the dose. So there are a few of those that are like that. Okay. All right. If there are other questions, I appreciate you guys today, and have fun at the conference.